For too long, domestic violence has been an invisible epidemic, hidden behind closed doors, misunderstood, and too often dismissed. At the S.E.E.N Summit, we believe every story deserves to be heard, every survivor deserves to be believed, and every person has the power to make a difference. Together, we are disarming domestic violence by shining a light on what's been unseen. With each episode, we are building awareness, deepening understanding, and creating space for healing and change. This is the S.E.E.N Summit Podcast, making the invisible visible, one conversation at a time.
All right, Dr. Jackson, thank you so much. Welcome to the S.E.E.N Summit Podcast.
Thank you for having me. So excited to be here.
Awesome. Well, you've mentioned before that you don't flaunt about your doctor in front of your name and all of those good things, but I am a podcast host, and thereby I reserve the right to read you your own bio and make you super uncomfortable. So for everyone that is listening, I would like to introduce you to Dr. Alisahah Jackson. Dr. Jackson is the president of the Lloyd H Dean Institute. She is a staunch advocate for health equity. For more than 20 years, she has designed strategies to improve population health, help vulnerable populations, and drive health equity as a clinical, academic, and operations leader for large health systems. She was most recently Systems Vice President for Population Health Innovation and Policy for Common Spirit, where she focused on strategy development for vulnerable populations, health equity, and innovative healthcare delivery models. She sets the strategic direction for the Institute, collaborates across Common Spirit to develop and expand humankindness research and health justice programs, and partners with the foundation to raise external funds to support the work. So, are you at all interested in health equity? Those words didn't pop up very much.
Just a little bit. Clearly, Mariah, and thank you for that warm introduction. I think I tell people, and I think this is true for a lot of us in healthcare, is that this is really a calling for me. To let my mom tell it, I came out the womb saying I wanted to be a doctor, and I will say, as early as I can remember, I remember having my little Fisher Price doctor's kit and carrying it around when I was little and doctoring on my stuffed animals and my family members. So yes, this really is a calling for me. And I think, I lost two family members pretty early on in my life, my grandfather and my aunt, my mom's youngest sister, both to cancer. And a big reason that contributed to their passing was a delay in care. And part of that, or a big part of that, was the fact that they did not feel comfortable. They did not trust the doctors in the health system where we lived. There weren't any doctors at that time that they had access to that looked like us. And I think that played a big role in them finally getting care. And so that kind of set my life path, if you will, because I remember thinking, even, at 6, 7, and 8 years old, that, I wanted to be the doctor for my family and, my community. And I wanted to make sure that everyone felt safe going to the doctor. And so yes, that has kind of been my life calling, if you will, to really help people get the care that they need.
That's phenomenal. I love reading people's bios, but honestly, like when I hear you talk about why you do what you do, you can hear the heart for it so well. And that's so encouraging. Well, first, before I get too far into all of the things that I want to pick your brain about pertaining to domestic violence, can you tell us a little bit more about the Institute? Because you are an expert of the crossroads of so many different things that I'm passionate about, which is, again, like vulnerable populations and across big systems, healthcare, one of which is a really, really big one, especially in the survivors community. And so please tell me a little bit more about this basis of kindness, compassion, empathy, and what that has to do with healing.
Yes, yes. No, thank you so much for for that question. So the Lloyd H Dean Institute for Humankindness and Health Justice is, believe it or not, only 3 years old. We just turned 3 in December of last year.
Happy birthday.
And when we and when we started, or I should say when I started, because I was the first employee, if you will, and I was by myself. But I was really asked to think about why now, like why should we be looking at human kindness and health justice at this moment in time? So again, think about this. This is the end of 2022. And um, how can we help our organization, Common Spirit Health, which many may or may not know is actually one of the largest nonprofit healthcare systems in the country? Um, how can we help our organization really start to accelerate our brand around Hello Human Kindness and put that into operations? So, and is there any research or science to support that? And so that's what I was really kind of tasked to do. And so spent the first year of the institutes really going around and talking to people. Talking, I shouldn't even say talking, I should say listening to people because I actually posed a lot of questions and then listened to what people said. One of those main questions was around what would you like? What would you like for this institute to do and to be? Um, why do you think this why do you think this is important right now for us to be intentionally talking about human kindness and health justice? And I mean, I visited all kind of different places I had never been. I had never been to North Dakota, but I got to go visit one of our critical access hospitals in Dickinson, Dakota, an amazing facility that's doing such great work. I went to LA, I went to Houston, I went to Phoenix. I just got to go and visit our teammates, visit our patients, talk to our community partners, and kind of pose these questions. And then at the same time, really diving deep into the literature. Like, what is the actual science of human kindness? And we really had to define human kindness because human kindness itself is a made up word. Like, you can't really find it in the dictionary as of yet. um, and so, what we found, what the literature told us, is that kindness, compassion, empathy, and trust really have decades and decades of science supporting outcomes. So, by exhibiting these things, by making sure patients receive kindness, receive empathy, receive compassion, have trust with their care provider, there are all these positive benefits to that. And again, that has been shown over and over in the literature. In addition to that, what we also found was that there are certain vulnerable populations who don't always receive those things. And those populations also tended to be populations that experience significant disparities. And so we are the only, as far as I know, and I've looked, done actually an international kind of search for are there any other institutes or centers that are really focused on the intersectionality of human kindness and health equity and social justice? And there's not. And so we feel we are in this very unique position to bring that to light, to make people aware that there is significant intersectionality and then hopefully make people believe what we believe, which is that by leveraging the science of kindness, compassion, and empathy and trust, we can accelerate improvements in health equity and social justice. So that's really what we're here to do. We're here to make people aware that these soft skills, often people refer to kindness, for example, as a soft skill, and we're like, they may be soft skills, but they're backed by hard science. And so, how do we actually help people learn the science, learn the research, but then also learn how to be more kind, more empathetic, more compassionate? learn how to build trust, because there are actual skills that we can teach. And so that's what we're on a journey to do.
That's phenomenal. And what I love about it, and I haven't found it anywhere else either, by the way. When I learned about your institute, I went on a hard Google search, like, who else is doing this? Where else are they doing this? And it really is, it's truly unique. And I mean, you said it's a calling and you started out employee number one. And I mean, I believe things like that have to be a calling because it doesn't exist anywhere else. So just so grateful that it's existing. So I'm going to go back just a little bit. This was post
Okay.
pandemic, right? We are looking at post pandemic,
Yes.
evaluating, inserting human kindness into the healthcare world. Um, and the healthcare world at that time had been drained of resources, had been drained of employees, it had been drained of so much. And just where in that did you find the the energy and the gusto to start injecting it with human kindness?
Yeah, no, I mean, thank you for that question. I think it was a difficult time, right? And part of what we talk about it, as a relation to building trust is being honest, right? And so, I think for a lot of healthcare workers, myself included, there was kind of this it was a time of burnout, right? Like, just burnout from mentally, physically, emotionally, dealing with COVID, and a lot of compassion fatigue, which again is something that has been well studied, especially in the healthcare sector. And then we were seeing this in our own, in our own facilities, in our own system. But then we said, well, let's look at what some of the social science data is telling us. And there were some very interesting things that we found at the time, which continue to exist today. One was that we found we were at the lowest levels of civility, since civility started to be measured in the US, which was around the 1930s. Um, and so that was, when I read that, there was a part of me that was shocked, but there was another part of me like, oh no, this is what I'm feeling and I'm seeing, especially on like social media. So lowest levels of
Yeah.
civility. We also found that we were at the highest rates of social isolation and loneliness. The previous U.S. Surgeon General had actually identified social isolation and loneliness as as an epidemic. And
Right.
and you might say, well, why would we care? Like, as a healthcare system or as a physician, why would I care about social isolation and loneliness? Well, what the research tells us is that if an individual is socially isolated or lonely, it puts them at risk for cardiovascular events at the same rate as smoking 15 cigarettes a day. So if you
Wow.
think about that, like in healthcare, we are taught to address tobacco use because we know that that has significant risk for cancer, significant risk for cardiovascular disease, significant risk for lowering life expectancy. It is a part, especially as a primary care doctor, like it is a part of what we do day in and day out. So then to find out that social isolation and loneliness has the exact same risk profile as smoking, let's just say, I mean, I was blown away by that. And the other interesting
Yeah.
thing around social isolation and loneliness was that I think we think about it as it relates to our seniors, so our elderly population, but the fastest growing age segment for social isolation and loneliness is young adults. So think about that. Even though we're the most digitally connected, right, than we have ever been in the history of the world, our young people are becoming the most socially isolated and lonely. And so that was just fascinating to me to think, oh my goodness, kind of what's going on and how has technology, there's definitely a whole lot of positives, right, to technology, but we don't often talk about maybe what are some of the negative effects that we're seeing from technology as it relates to social connection. Um, and then the third thing I would say that we found that was really interesting was we are at the most unchurched period again in the history of the US. And so when I say that, I tell people I don't say that from a perspective or from the standpoint of like religion per se, but I do say that from the perspective that for centuries places of worship served as community hubs, right? They served as places where people would come and gather and
Interact.
connect,
Yeah.
right? Interact. They also often served as places where we learned the skills of kindness and compassion and empathy, right? And now, not as many of us are attending a place of worship on a regular basis. And so, where has that shift happened? Like, if we're not going to a place of worship to maybe learn some of these skills that we used to go and learn, like are we being taught that any place else? Is it happening in our schools? Is it happening at our jobs? Where is that happening? And what we realized was like, oh, it's not. It's not really happening anywhere else. And so that was another reason why we were like, okay, there's this opportunity for us to really at least think about our 157,000 employees and say, well, can we teach some of these things to our employees? And so that was a year of discovery, I would say, and again, what we heard from everyone that we talked to was, can you help us from an education standpoint? So tell us what the research is and what the data shows. Can you help us from a training perspective? So can you teach us how to be more kind, how to be more empathetic, how to do quality improvement with a health equity and a social justice lens? So the training aspect, can we continue to add to the body of knowledge? So even though there's a lot of, I would say, a lot of research out there on kindness, compassion, empathy, and trust, health equity, and social justice, there's really not a lot on the intersectionality of those things. So again, we felt like here's a chance for us to add to the research. And then how do we evaluate? How do we look at the things that we're doing and making sure that we're embedding human kindness and health justice principles into that work? And so in order to do that, you have to have an evaluation framework, right? That is available for people to use. And so those are really the things that we're focused on at the Institute.
That's wonderful. I'm so grateful that it exists, and I'm wondering because everyone has a connection to domestic violence somehow. They're either a survivor or they know someone who is, or they provide care or leadership in some way for someone who's experienced it. So when we're looking at this concept of human kindness, as you've come to define it in these practices, what are some of the ways that that shows up as support to survivors in healthcare?
Yeah, well, one, Mariah, again, thank you just so much for the work that you're doing with this podcast. And I love the fact that it's called Seen, because I often refer to some of the vulnerable populations that we take care of as invisible populations. And this is one of those populations that I think is often invisible. And so when you think about who's disproportionately impacted. So there are disparities that even exist in domestic violence. So when we think about who's disproportionately impacted, those populations include lower socioeconomic status. They include um, lower educational status, housing insecure individuals. When you think about it from a gender perspective, women, although, as you know, we are starting to see an increase in men who are also experiencing domestic violence issues. We see disproportionate risk in communities of color. So again, they're already like I said, and I feel like an invisible population, and then there are even disparities within it, right? And so
Yeah.
really being mindful of it, and I tell people that one of the biggest reasons that it's important to understand who who these invisible populations are and who is at higher risk is because then it actually impacts how you care for people when they are across from you. And so you need to be mindful that, when certain populations are sitting across from you, that there is a possibility that some of these things are even going on. And, often in this community, the individuals have become experts in hiding, right? And so that means it takes it places more responsibility, I would say, on us as providers to make sure that we're able to identify and support. And so I think that's one thing. Again, looking at what does the research tell us, there is actually research in the domestic violence space. I would say specifically more around empathy, compassion, and trust. But the research is very clear for survivors, especially who are receiving empathetic care from whether that's a clinical provider, a mental health provider. There's been quite a bit of research in the mental health space from like counseling and therapists that if there's an empathetic relationship between the care provider and the individual experiencing domestic violence, they have better outcomes. So they have better clinical health outcomes. They have better or improved behavioral health outcomes. They tend to um, the willingness to share or engage with the provider is there in a much higher rate. Um, there was some study that was interesting enough teaching survivors self compassion, how to give themselves compassion and show love to themselves actually has improvement in outcomes as well, specifically around individuals experiencing PTSD. And so I thought that was really interesting too, that there's this research around, how to show yourself love, right? And how to show yourself compassion and not to blame yourself for being in, a situation. And then from a trust perspective, trust is probably where there's been the most research done. And again, really around trust, not only with clinical care providers, behavioral health providers, but also the systems that are often involved in domestic violence situation. That includes the criminal justice system, right? And so again, when there is a trusted relationship built with these entities, the survivors have better outcomes. And I will just caveat, I thought the trust research was so important because it aligned with trust research in other areas. And so there's a lot of trust research in business sector, again, in the healthcare sector, in the educational sector. So trust has been probably one of the most well studied, if you will. But a couple of key themes throughout all of the industry that also showed up in research with domestic violence situations was three things. One, trust is bidirectional. And so I say that because I think I will just tell you, as a physician, I was kind of taught that once I finished medical school, once I finished residency, I finished a fellowship, like I'm the expert, right? And so you should trust me because I've done all of this training and I'm the expert. And the reality is, and part of how we're training our residents and our medical students now is that yes, you might be the expert from a clinical diagnosis or clinical treatment standpoint, but the person sitting across from you, they are the expert in their own lived experience, right? I haven't walked in your shoes, Mariah, so I can't tell you how it feels to be X, Y, and Z, right? But I do have to trust you enough, and hopefully we get to the point that you're willing to share your story with me, and then I have to honor your lived experience, right? And so I tell people, like, that's a shift. That's a shift for providers.
I'm grateful for the fact that you called out that it has to be two ways. It has to be trust two ways. It's a bridge. It's not a one-way street. And the other factors that you're talking about, like kindness and empathy, they're foundational to that bridge because, like, for instance, I've had a provider wherein finally someone was willing to actually separate me from my abuser at the time in an appointment, and ask for me to be separated and then to ask me questions. And that was the closest at that time to disclosing that I came. I was still too afraid to do it because my abuser worked in that same healthcare facility, but it was the closest that I came to someone actually trying to build that bridge with me of communication where we could have some trustworthy communication. And then when you're talking about trauma specifically, if there's not some even effort towards empathy, right? Even that half a second extra toward I might not be able to walk in your shoes. And so maybe I can't walk in your shoes. Maybe I haven't been through what you've been through. Maybe I don't relate to the actual experience of trauma, but I'm going to take the extra half a second and I'm going to understand that I don't understand and let you provide me with the information that I'm lacking about you. So I thought it was so important that you called that out, especially for survivors of domestic violence, because so much of the time, if there's physical abuse, there's also going to be that mental abuse portion. Um, and when that's the context, reality is very often being force fed by someone that they've trusted or I've trusted. And then I loved that you said that you even going back to talking about your aspirations to become a doctor when you were younger, was that you wanted healthcare to be somewhere where patients could come and feel safe. And for survivors specifically, there's probably not somewhere else that they're feeling safe. And the fact that you've devoted this entire institute to finding ways to make sure that we're being safe leaders, we're being safe stewards. Identifying was a big part of what you said, who's vulnerable, um, and then finding ways to start building those bridges for trust. I mean, that's so phenomenal. So tell me a little bit, because you've talked about two kinds of reparations that I'm just really touched by. And one of them is like individual repair for a human being, right? A human being is coming to one of your healthcare facilities in need of healing for whatever it is. And then you've also talked about a systematic repair that your institute is kind of taking the charge on and making sure that from this broad perspective, you're affecting change into the systems. So it sounds like it's more than just healing bodies. It's healing an environment that's been broken. Do you want to talk a little bit more about that?
All right, you just laid that out beautifully, first of all. So let me say thank you for that, because I think it's an and. Um, it's interesting. So I'll use as you can probably tell, I like stories. I'm a storyteller. So I am a faculty member, so I still have the pleasure of teaching medical students, nursing students, residents, all kind of different students. I love to teach. And I tell people as faculty, we typically have little quirks, right? And so I have one that I openly acknowledge. I'm sure there are others. But um I was precepting a young intern a couple years ago, and she was presenting the patient. So she was like, this is Mr. Smith. He's a 65-year-old Caucasian male with diabetes and high blood pressure and high cholesterol. And he's not taking his medicines and he's not eating right. He's just non-compliant. And she was like, had this exasperated kind of look on her face when she said, he's just non-compliant. And one of my third-year residents was, like, walking in the room when she said that, and he heard her, and he immediately his eyes got big, and he just turned around and walked out and kinda left her there by herself. And he did that because he knew, "Uh-oh, she just said the one thing that Dr. Jackson is
Gosh.
completely against, which is, I don't believe in non-compliant patients. I actually am on this. I would like this grassroots movement to remove that terminology out of the EHR completely. Because I don't think people wake up, right, and go, "Oh, my goal today is to be as unhealthy as I can be." I don't know anyone who does that.
Yeah, and
Uh,
for people who are listening, EHR is electronic health record.
yes. Thank you, Mariah. And so, I think we all have barriers, right? We all have barriers to achieving our best health. And as a provider, I think it's important for us to help people work through those barriers. So, again, if you're coming from a place of how do I promote healing for this individual, recognizing that health encompasses physical, behavioral, spiritual, and that there are all of these factors outside of an individual that are also contributing, right? There are these systems in place that are also contributing to a person's ability to heal. And so, yes, there is the one-on-one. I will just say, finishing up that story, I gave her my spiel. I knew Mr. Smith, so I knew some of the things that he had been dealing with. But I told her, I said, "Okay, we don't use that term, but you said he's not taking his medicines. Why?" And sometimes it's like I tell people to use the 5 whys. If you ask a question 5 times, if you
Yeah.
ask why, have you heard of this 5 times, you usually get to like
Yes.
the root cause of what's going on. And so for Mr. Smith, he was recently widowed. He and his wife were retired elementary school teachers. They had worked in the school system for almost 40 years each. But when they retired, they were on a fixed income, right? And so they were living in a neighborhood that did not have a full service grocery store. They relied on public transportation. His wife was the one who actually did most of the meal prepping when she was living. And so he was going through this transitional period, right, of losing his wife, having to navigate now meal prepping for himself, being able to get to and from the grocery store on a public transportation system that in that city, I will tell you, was not set up to be easy for people. And so there were
Was
just
this North
all of these
Dakota?
no, not North Dakota, but I won't put the
I don't
city
know
on blast.
anything about it.
But it was just challenging. It was really challenging, and there were all these other external factors, right, that were going on in Mr. Smith's life. And so, again, I think recognizing that there's the individual repair, as you mentioned, that we need to support, but we are all leading in these broken systems. And I think it's okay for us to acknowledge that. I tell people it's often I find it's shocking that people are shocked when I say we are the most expensive healthcare in the world and we have the poorest health outcomes as it relates to industrialized countries. So I'll say that again. We're the most expensive, but we have the worst outcomes. We have the lowest life expectancy, again, as it relates to other industrialized countries. We have the worst rates for maternal and infant mortality and morbidity in this country when compared to other industrialized countries. Um, so, how is it that we're paying all this money and we're not getting a return on our investment as it relates to health outcomes? And so I think it's just, we have to be honest, right? Going back to how do you build trust? You have to be honest about the things that are happening, and we're leading in these broken systems. And so how do we actually create, I always talk about creating new systems, of course, also continuing to try to fix some of the systems that we're in. But I think the biggest opportunity is for us to create new systems that really, for us, we're saying apply the principles of human kindness, apply the principles of health equity and social justice. And by doing that, you're going to create healing systems that, of course, support healing individuals.
And it's almost like you're talking about new systems of thinking too. I mean, women's healthcare in general has undergone such a transformation, right? I mean, everything was just hysteria forever and a half, right? We
Yes,
didn't have any
so
actual
true.
medical issues. It was just hysteria. And so when you're talking about Mr. Smith, which for all intents and purposes, you ask five whys and you've found out an actual addressable cause for why he's not able yet to have followed his treatment plan. And then I can think right now of a patient that I've interacted with um, who really needs surgical intervention. And she's in an abusive relationship. She doesn't get access to her phone. So she doesn't get information about her appointments. She doesn't get referrals scheduled. Um, she doesn't have access to a car. She can't get herself to those appointments, even if we get those appointments scheduled. Um, I will say, uh, I have watched physicians insist upon some separation so she can get questions asked alone. I've known that she's been offered to connect with resources. So there are some positives that I've watched happen through her care team. Um, but for the circumstances that isolate her from her actual care, I have also watched other care team members say things like, ugh, surprise, surprise, she didn't show up. And for you, I think your trigger word was non-compliant. And for me, my trigger is patient blame and things like that. And I'm like, uh-huh. And what have you done to try to fix that? And who have you reached out to? Had someone from the office called? Like what um
Yes.
I wish that the surprise surprise was that there's a member of a healthcare team that would say surprise surprise like that about someone who's a human. And that's why I love your absolute
Yes.
devotion to this human kindness movement. So, for people who are listening and they're navigating the healthcare system, how can they know some flags for I've found a safe healthcare provider? Or what kind of things should I be advocating for in my healthcare relationships?
Oh my goodness. I love this question. And I will say, especially as it relates to women, although I think it applies to everyone. But, women, as women, we make 80% of healthcare decisions in this country. So just think about that, even for yourself, like you're making decisions for your own health often. A lot of times you're the one making the decisions for children, right? In their healthcare. If you're in the sandwich generation like myself, I'm now, power of attorney, healthcare power of attorney for my mom. So I'm making all of the health decisions for her. We even sometimes are making health decisions for our spouses, right? And so encouraging them to get their appointments and like so we actually again, this is what
Sneaking
the research
spinach into the frittata.
like, we're making a lot of times the decisions on what we're eating, right? Because we're so it's like we make 80% of healthcare decisions in this country. And so yes, one of my big thing is around how do we empower women, but like I said, everyone to advocate for themselves and make better decisions. So I think a couple things specifically around kind of what to look for in a provider. Um, some of these are going to just seem so simple, but again, this is what is supported by research. So the first one is, believe it or not, I would say, is eye contact. Does the provider make eye contact with you when they come into the room? Do they acknowledge you? Do they introduce themselves if it's the first time that you're meeting them? Do they sit down? We call it heart to heart communication at our organization. And this is how we train providers. And we say that because as much as possible, if you're heart to heart with someone, then you're going to have eye contact, right? But what we know is that with the introduction of electronic medical records, eye contact actually went down because providers now are so focused on what I call data entry, like putting all the information into the computer, that that ability to really connect with the patient through eye contact has decreased. So we're trying to bolster that back up. So that's definitely one thing right off the bat that I would say, if a provider doesn't make that initial eye contact, um take note. But then also there's an opportunity. They're going through so much. I tell people, like, sometimes, like, especially as a primary care doctor, I might be scheduled for like 15 minutes for a patient, right? Like, I'm trying to, like, get through 30 people in a day. And again, these are systems that are in place that I don't necessarily have control over at all. And so using that opportunity, if the provider didn't make that eye contact, to just say, hi, my name is Alicia. Nice to meet you. Put your hand out, for them to shake your hand. Cause again, that automatically kind of makes them, right, look at you, shake your hand, etc. Eye contact. That I will say that's a key one. And then the second thing I will just say, and then I'll move to the other part of the question. But I think the second thing is around um just the provider acknowledging you, and again, what I call honoring your lived experience. So even if they are from a different background or culture, or they maybe haven't experienced the clinical condition that you're going through, they should be listening. They should be nodding. So those nonverbal cues are really important. So, are they listening? Do they have the eye contact? Um, are they questioning to um, listen and understand, and not questioning to um, poke holes, if you will, into what you're saying. And I think we have all been in those experiences, like where we intuitively know if someone is listening to understand versus listening to fix, for example, or just kind of get to, okay, I hear you, but this is what you need to do, right? Like, that's not, this is supposed to be um again, if we have a trusted relationship, or we're working towards building a trusted relationship, it's supposed to be bi-directional. It's going to take time, and you should be honoring, me as an expert in my own lived experience. So those are the things that I would just those two things that I would just say right off the bat. If you have a provider who does that, like, yes, that's a good one. Keep them. And the other thing is, even though I know it's difficult for access in our country, especially for specialists, right? But always know that you have the ability to ask for a second opinion, or go to someone else, as much as you can, right? That's not always the case. That's not always available, especially given like rural communities, and other, different insurance requirements, et cetera. But if you don't have those restrictions, then I tell people it's okay to go get a second opinion. I would tell my own patients, go talk to someone else. Like, don't just take my word for it if you're, still questioning what the recommendation is. And so I think that's the other thing, just from an advocacy for yourself standpoint, just know that you can go talk to someone else.
That's phenomenal. And I'm thrilled with the fact that when I asked you, how can I know if I've got a good provider, you didn't say anything about the piece of paper framed on the wall. You didn't say anything about that. And that's important. And that's
Yes,
important.
it
I
is.
I think it's important because what I'm hearing from that is that these principles of kindness, compassion, empathy, and trust, it's not an optional or elective or extra level of care. These are the first things that we have to look for. These are the first things we have to, like what your institution is doing to train providers in. But I think so often when people are looking for care, they're sort of given the impression that, well, if your doctor's also human, that's great, but mostly you just need what's in their brain to fix what's wrong with your body. Um, and I think from a less educated standpoint, it's easy for our hearts to understand that we're receiving the care we need when we do receive empathy and compassion, when we can establish a trusting relationship with a provider. Like you said, it should feel safe, and our hearts know that. And so to have you come on and validate for us that that really is where healing begins, not just from, and God bless all of you who have gotten these degrees in medicine, because oh my goodness, what an undertaking. But it isn't just that, right?
Yes. No, it definitely is not just that. Of course, it's foundational, right? I mean, so I want to be clear, like we do go through all the training, right? The 4 years of medical school, the 3+ years of residency, depending on your specialty, for those of us who do fellowships even after residency. But again, all licensed providers, especially physicians, so I'll just speak to physicians, like we all have gone through that minimum. So there is a level of competency, right? That is in place. And I do want to be clear, that's important. But for the most part in this day and
Yes.
age, especially for physicians who are employed by large systems, there are kind of checks and balances in place to make sure that we are continuing to remain competent in our clinical skills. And so that's why I'm like, that is one of the systems that I think is working pretty good in the healthcare industry. Um, so then it's like the next step, right? Like, what are the things beyond that competency, that baseline, that foundational competency? What are the things that I should be looking for? And these are these intangible things that I really do think well, not even I think, what the research tells us improves outcomes in the long term. And so that connecting back to our shared humanity, like that's what you should be looking for. And if you're with a provider that you don't feel that, then maybe you should look for another provider and that's okay.
Wow. Thank you so much for that. I know I have taken up all of our time. I am just so thrilled to have gotten to pick your brain. We're so grateful for everything that you're doing. Just to close out a couple things, I would love to know how you practice taking care of yourself in this crazy world. Would you share that with us?
Yes, yes. No, thank you. So this is I am an avid reader. I read all kind of stuff. I'm the person who's reading like 3 or 4 books at a time. And so I'm usually reading like something for work, but then I'm reading something for pleasure. I'm in like fantasy right now.
Love
So
it.
uh I love to read. I spend time with my family. I have 2 boys, one who is away at college now, but one who's a junior in high school, and my husband. So we spend a lot of time like, I'm surrounded by men, so I do a lot of sporting events. Go to a lot of sports activities. And then I really have been intentional about, again, thinking about what the research tells us in regards to health and well-being and healing. So being physically active, and being outside. So this year I've been trying to do more intentional walking outdoors. So I can kind of get that sunlight, that vitamin D that we all need. And also, move my body, if you will, to get some of that physical activity. And that's also helped. I would say I feel like it's kind of helped me even mentally sometimes to just take a pause and a deep breath and breathe the fresh air and just take a moment to relax. So those are the things I would say I'm doing right now.
Awesome. Thank you for sharing that with us. I will sign up for your personal book club.
Oh,
Uh,
wow. We have the Common Good Book Club coming up, Mariah. We
I
do
know
have the
it.
authors. So April 1st, join us.
I will be there. And then for everyone else who's listening who wants to learn more about the Institute or find out more about you and all the good work you're doing, where can they find that?
Yes, yes. No, thank you. So We are actually, believe it or not, on almost every single social media platform, including Reddit. We just launched into Reddit. So if you just go to Instagram or Facebook, LinkedIn, Reddit, and just put in Lloyd H Dean Institute, you can find us. We'll be the first thing at the top. We do also have a website. Again, I would just say Google us because it's much easier versus our website is really long. But yeah, so we do have a website that you can go and find out more information. And then we do hold a virtual summit every September. This year will be September 24th. That is actually open to everyone, not just our own employees. And again, it's virtual, so you can join from your work, from your home. We would love to welcome you on that. And Mariah, we can also, once that link is available, we can send that to you and you can send it out to your listeners as well.
Fantastic. Well, thank you again so much for taking the time.
Thank you. Thank you for having me. This was a wonderful conversation. And thank you so much for everything you're doing.
Thank you so much for being a part of the S.E.E.N Summit. The movement to end domestic violence starts with you. Keep tuning in because when we come together, we are disarming the monster that is domestic violence of its most terrifying weapon, its invisibility. We are a community of survivors, loved ones, and leaders together making the invisible epidemic seen. Please share what you've learned today with others. When you subscribe, like, or share this podcast, you help us to reach more individuals and organizations who can make a difference. We'll see you next time at S.E.E.N Summit.